So I'm going to try to wrap it up here for y'all. And after this, we do have a lunch. So please hang with us. That's where we're going to ask some of our speakers questions that you may have had. So just to sort of wrap this up, I think we're getting a feeling of the fact, and I think it's something that I alluded to in the beginning, and that is that sometimes in our hurry or by the way medicine has changed and in the fact that we have sometimes very little time, to deal with our patients, we tend to miss, the fact that we have to consider all these other issues with our aging patients. Quite honestly, sometimes the easiest part of our HIV aging patients, that we have to deal with is their HIV, right? That's sometimes a slam dunk, viral load undetectable, everything, but we need to start paying and focusing more attention. So if nothing else, I think the fact that we discuss these things and maybe we don't have all the minutiae brings it to the forefront of our mind. So I started off the conference by talking about where we've been. This is where we're at. Where are we going? Right. And so basically, I'm going to try to get through this a little quicker. So long-acting injectable medications is probably of the forefront right now. And my disclosure is that I speak for Gilead Sciences. So why long-acting injectables? So those of you that have been around for a while, we went from 18 pills a day, more or less, to be taken without food every 3 hours. It was impossible, for our patients to take that. So even though none of these medications at this time is a silver bullet, through the 30 years, we have improved medications that have improved adherence, which have secondarily improved life expectancy. So don't be, I know a lot of patients, and rightfully so, become a little bit, sad because we don't have that magic bullet. But every step forward is a step toward that, I believe. And right now, one of the major things that we have is long-acting injectables. And they're improving adherence, especially for those people, that can't take oral medications. An old goat like me who has high blood pressure, high cholesterol medicine in a pill box, it would be just another pill. But for some younger people, taking a pill a day is a big deal, when you're not, used to it. And for some people, there's a reduced stigma. You don't have to have pills. You don't have to hide it from your family or your friends. You can just go. And this is probably more important in different countries throughout the world, especially in African countries where there is a huge stigma, and some very macho countries in South America. And I can say that because I am Hispanic. So we go forward. So it does decrease stigma and also pill fatigue, which is a real thing. And it just expands prevention options and improves durability of suppression because there's better adherence. So just to go over what we have available for us, we have cabotegravir, long-acting, which is Apretude. All right. And this is for prevention. This is for PrEP. And it's highly effective PrEP option that you get every 2 months. And now, most recently, lenacapavir for PrEP, which has the very horrible name, Yes to Go. That's my opinion. All right. And that's every 6 months. And it's almost actually the information that was presented at the last IAS was 100% protection, right, in the African study. So it can be a game changer for prevention. Also, their FDA approved long-acting injectables for treatment, Cabenuva, which is a combination of cabotegravir and rilpivirine, intramuscular injections every 1 to 2 months. And also lenacapavir, the same thing as Yes to Go, but for treatment called Sunlenca, which is a subcutaneous injection. Now, Sunlenca is usually used for people that are highly experienced, almost as a salvage treatment, but it is an injectable that is available. So there are tons of long-acting injectables in development right now. They're long-acting integrase inhibitors, long-acting neutralizing antibodies. And personally, I think that neutralizing antibodies is going to be like the next big thing in HIV treatment, both in combination with things that we have available and perhaps solo and combination injectable regimens. And I'm not going to bore you with all the names, but there are many agents in clinical trials. They're next generation integrase inhibitors, capsid inhibitors, that have been optimized for long-acting delivery, combination of injectables, biological biologicals. So here you have a list of long-acting injectable treatments that are in the pipeline as of this year. So we have lenacapavir with cabotegravir, lenacapavir with Gilead integrase inhibitor, lenacapavir with broadly neutralizing antibodies, et cetera, et cetera. And we go forward. And again, this is nothing that you need to know right now. The major thing that I was going to say is that who knows? 2 years from now, we may be at a conference. It'll be like 1996 again. And there'll be something that they say, hey, look at this. You get this, and for 2 years, you're in treatment. And we can't give up hope. If we had given up hope, y'all wouldn't be here, right? So we are still here fighting this fight. And I just wanted to end with this. So the take-home message, I'm going to stop that. The take-home message is that there is so much research going on and what can happen. I don't know how many of you were in Vancouver in 1996? You were, all right, that was an aha moment, all right, in HIV treatment when they came out and said, look at this. Where they thought we were gonna cure it, and unfortunately they were wrong. So the take-home message, I think, from this conference is the fact that luckily we have made our patients live longer. And with that come a lot of other issues that we need to focus on. We've talked about the brain, we've talked about the heart, we've talked about the bladder, we've talked about the anus, we've talked about the genital region, we've talked about it all. All right. So those of us that are providers, we just need to be more aware on a day-to-day basis, the fact that we are treating total patients, not just people that are HIV positive. I also want to take this moment to thank the practitioners, all of you, whether I work with you or not, because everybody's doing, their part. And don't think that what you do is insignificant. I know that the day-to-day frustrations are many, and what frustrates us nowadays isn't so much the medicine, but how we have to practice it. And listen, I'm the first one that gets PO'd. For those of you that have worked with me, do you know how I can get? All right. And sometimes we have to rise above ourselves, and realize that we are doing a lot of good. And let's not forget that. You've endured us for 6 hours. I appreciate you all being here. I count on you coming next year, bringing friends. We're going to make it bigger and better every year. Thank you.